In this section, we'll review the effects of 3 drugs that have similar properties as the benzodiazepine derivatives. However, their chemical structures differ slightly from benzodiazepines, so their mechanism may not be identical. Glycerol guaiacolate is a sedative and skeletal muscle relaxant used primarily in the horse. Methylcarbamol is a skeletal muscle relaxant used in both dogs and cats, as well as the horse. And meprobamate is a skeletal muscle relaxant that's not as widely used in veterinary medicine, but can be used for GI disorders and nervousness in dogs. You can see from their structures that they differ from each other, and that's the basis for their different spectrum of action. Glycerol guaiacolate, or GG, or guaifenesin, are all names for the same compound. It's used as an adjunct to anesthesia, primarily in the horse, but it can also be used in swine and cattle. GG produces sedation that progresses to hypnosis, but it's not safely administered by itself as an anesthetic. Not only does it cause some sedation, it also potentiates the depressive effect of other compounds, which is pivotal to its use in anesthetic combinations. In addition, GG produces a good skeletal muscle relaxation at doses that induce little or no respiratory depression. There are reports that it's analgesic, but also some reports that refute this claim. There does seem to be a consensus that it potentiates the analgesic effects of other drugs like paracetamol, acetaminophen, and aspirin. It's used orally in human medicine primarily for its expectorant properties. Think of preparations like Robitussin or Mucinex. As an expectorant, it increases ciliary action along the respiratory tract, increasing the volume and decreasing the stickiness of mucus. This allows congested airways to clear more easily. Finally, it's antipyretic. This means that it can decrease an elevated body temperature, but it's not hypothermic. That is, it doesn't decrease normal body temperature. So only the increase in temperature that's associated with infection or endotoxemia is decreased by antipyretic compounds like guaifenesin. When guaifenesin is used as part of an anesthetic mixture, it's delivered very rapidly IV in a large volume of saline. Because you need a freshly made solution, it's usually best to be near a compounding pharmacy. In a horse, a large bore needle is usually placed in the vein and attached to a large injectable tubing attached to the bottle of guaifenesin. A pre-medicating dose of something like xylazine can be injected into this tubing, followed by a rapid infusion of GG that will eventually cause the animal to become wobbly and visibly sedated, and lowering its head, for example. At that time, you can inject the anesthetic compound, usually a barbiturate or ketamine or propofol, directly into the same tubing, and the animal will generally go down smoothly. Additional guaifenesin can be administered for up to 60 minutes to keep the animal down. Giving GG longer than that will likely not work and even make the animal more excited rather than less excited. So refrain from trying to extend the anesthetic episode with GG alone. Instead, use ketamine or xylazine to maintain the anesthesia. For short procedures, the recovery usually mirrors the induction. If the animal is kept down for as long as possible by pressure to the head while lifting the halter, the animal will eventually stand without too much assistance. This photograph shows the bottle and tubing used to administer the GG as part of an induction of anesthesia. Once the horse shows signs of muscle relaxation, including ataxia, lowered head, buckling of the carpus, Ketamine can be administered into the tubing to complete the induction. To maintain the anesthesia, the bag can contain the GG, ketamine, and xylazine. The purpose of this photo is to emphasize that the use of GG is not a one-person job. In addition to plenty of manpower, you need a compounding facility for the compound nearby. So a medical facility is the best location for its use. The reason for the large volume of dilute drug is that higher concentrations will cause venous thrombosis and hemolysis. The maximum concentration that should be delivered is a 5% solution. Given its use in large animals, this ends up being a very large amount of fluid that needs to be infused, so the large bore needle and the cannula are essential. Old solutions also can cause venous thrombosis, so ideally make the solution up fresh each day, although it can be used for several days. Because of this type of infusion, that is a large volume of drug, it's not a good pre-anesthetic for small animals. Remember to re-administer GG for only a maximum of 60 minutes because an overdose can mimic an underdose, causing transient excitation, increased muscle tone, and a rough recovery. Guaifenesin is contraindicated in animals with physostigmine, that is, the tertiary amine used to test for narcolepsy, and other types of anticholinesterases. It's not really clear how guaifenesin causes its sedative effect. The effect is primarily central and not like curare that acts exclusively in the periphery, directly at the motor neuron junction. For many years, it was claimed to involve inhibition of spinal neurons that may be linked to GABAergic activity in chloride channels, similar to benzodiazepines and many other sedatives. However, more recently, it's been shown to inhibit N-methyl-D-aspartate, or NMDA receptors. This is something that ketamine-type compounds also do. However, the effect of ketamine is clearly different than that of GG, so it's still a mystery how it works. During anesthesia, GG is used exclusively as an IV injection. It doesn't cross the placenta, making it relatively safe for pregnant mares, and it's metabolized in the liver and has a half-life of about 60 to 85 minutes in the horse. There are two other skeletal muscle relaxants that we need to mention. Methylcarbamol is a derivative of GG, and meprobamate is loosely related to benzodiazepines. These two compounds have the advantage of blocking abnormal muscle activity, or spasms, and strychnine-induced seizures without completely blocking the normal muscle tone. In addition, there's sedation and some ataxia. The mechanism of their action is still not clear in either case, and now that drugs are widely marketed in these areas, there's no drive to clarify this issue. It's been proposed that methylcarbamol inhibits carbonic anhydrase centrally and potentiates the muscle refractive period peripherally. Whether these two events cause the muscle relaxant effect is really not clear. Meprobamate is proposed to block polysynaptic spinal interneuronal activity and potentiate the effect of barbiturates, as does diazepam. Regardless of the mechanism of action, they maintain normal muscle tone at doses that prevent muscle spasms. They also inhibit strychnine-induced seizures and produce sedation and ataxia. Methylcarbamol is used in both large and small animals. In dogs and cats, it's useful for intervertebral disc syndrome, muscle trauma, myositis, bursitis, synovitis, post-muscle surgery, and treatment of strychnine poisoning. In addition to these, Except for intervertebral disc syndrome, it's also used for tying up disorders in large animals. Meprobamate is used more for GI disorders in dogs, restraint of primates, muscle spasms, and also as an anticonvulsant in cases of strychnine poisoning. It can be used orally and has minimal protein binding, so there's less interaction here with other drugs, and it's metabolized in the liver. A final word of warning that you should share with clients is that they should be compliant with their dosage regimen. The drug should be terminated gradually, especially after prolonged treatment with high doses. Otherwise, you risk causing seizures. This slide compares and contrasts these drugs. They all cause sedation. In addition, benzodiazepines also produce muscle relaxation. They're anticonvulsant and they're anxiolytic, that is anti-anxiety. GG produces skeletal muscle relaxation and maybe some analgesia. Methylcarbamol is used for its muscle relaxant effects, but is also anticonvulsant. And meprobamate is used for GI disorders, perhaps related to anxiety. Each has a slightly different constellation of effects, and because of this, a different species of patients in which they're primarily used. Sedation may be the desired effect when used as, for example, a pre-anesthetic, but a side effect when used as a muscle relaxant. This summarizes things to review with clients whose animal has been prescribed a benzodiazepine. Indicate the reason for the prescription and how it overlaps with other effects produced by that drug. You may want to elaborate on the possibility that tolerance to the sedative effects will develop over time if this is not the desired effect. Stress the importance of compliance by describing how seizures may occur in response to a rapid withdrawal of the drug. The idiosyncratic excitatory effect of the drug should be described so an alternate treatment can be arranged in this event. And always warn of the possibility of allergic reactions if the effect of this particular drug isn't known in the patient. Keep a file of references or drug inserts to check the possibility of drug interactions when prescribing multiple drugs to the patient in the future. One way to learn the characteristics of each group of compounds is to compare and contrast them side by side. Here we've listed the types of qualities that are important for their clinical use. What you need to be able to do is describe the effect that phenothiazines like acepromazine have on that characteristic and how that compares to the effect of benzodiazepines like diazepam. For example, both types of compounds produce sedation. However, as you increase the dose of acepromazine, the effect is to produce catalepsy, whereas the effect of benzodiazepines is to produce more depression resulting in hypnosis, the induction of sleep. Remember that neither type of drug produces a safe anesthesia. If you inject these compounds rapidly, you may produce seizures using acepromazine, but when injecting diazepam rapidly, you're more likely to produce a transient apnea. If the patient is subjected to loud noises or bright lights after injection of the drug, they're more likely to be roused and hyperresponsive after ACE and less responsive to these stimuli after diazepam. Acepromazine produces much less respiratory depression at a sedative dose than diazepam. And acepromazine has no ability to inhibit seizures and may even be avoided by some veterinarians in epileptic animals. There's evidence lately that such extreme measures may not be needed, but it's a long-standing practice to avoid them in epileptic animals, whether it's necessary or not. In contrast, benzodiazepines are excellent anticonvulsants. Muscle tone is maintained very well after administration of ACE, while diazepam is even used to produce skeletal muscle relaxation. This, together with sedation, causes more ataxia after diazepam, resulting in a drunken-like animal. Temperature is affected by both types of compounds. ACE is poikiothermic, that is, allowing the body temperature to change to the ambient temperature, while benzodiazepines are hypothermic. There's little or no dependence liability when using ACE, but the benzodiazepines and muscle relaxant compounds produce a high degree of dependence after prolonged use. They're commonly abused drugs and for this reason more highly regulated. There are important but distinct drug interactions for each of these compounds. When used as a premedication, ACE can block the emetic effects of compounds like apomorphine. ACE can also prevent epinephrine from increasing blood pressure, and instead they unmask a hypotensive effect of epinephrine referred to as epinephrine reversal. In contrast, benzodiazepines are cross-tolerant and cross-dependent with alcohol and other barbiturates, so they're commonly used as substitutes for each other when abused. The reason for all these differences is because their mechanism of action differs dramatically. Ace-promazine competitively blocks norepinephrine and dopaminergic receptors, while diazepam and its related derivatives increase the activity of GABA-mediated chloride channels. To use these common drugs successfully, you should be able to fill out this chart by yourself and understand each of the points of comparison. This will help you generalize the types of effects of the drugs in each category. Then, you should be able to name the drugs commonly used for muscle relaxation, compare their constellation of effects to each other, compare their effects to other sedatives like acetylpromazine, ace-promazine, define their clinical uses, and recognize problems associated with their use. Because obviously, no drug is perfect for all situations.